Hello everyone, welcome to your OB course. This is Professor Sandino and today we're going to be talking about the newborn, the physiological and behavioral responses of a newborn. So first we're going to talk about the transition to extrauterine life, the adaptation, how our baby goes from being in utero, where he's in a nice, comfortable, safe environment, to living the extrauterine life. So one of the most important components or processes that occurs during this time is related to the respiratory system. In utero, the lungs are bypassed. Circulation goes to the lungs merely to maintain the tissue alive. However, when the baby's born, that changes and now they have to start functioning, right? So what happens is the cord is clamped. The baby takes his first breath, hopefully after the baby has been suctioned. Remember, we always suction the mouth first and then the nose. This usually occurs once the fetal head is, or the baby's head has been delivered. Once the baby takes the first breath, this results in an increase of alveolar oxygen tension and then a decrease in arterial pH, which results in dilation of the pulmonary arteries and decreased pulmonary vascular resistance. As a result of these changes, we have an increase in blood flow through the pulmonary vessels, increase in oxygen and carbon dioxide exchange within the lungs. And this is how we initiate the respirations in a baby. There are some factors that can affect this. For example, when you have babies who are premature, that have decreased levels of surfactant related to immature lungs, these babies do not progress in that fashion. Sometimes there are things that inhibit that. So when the surfactant levels are low, the baby sometimes cannot have proper oxygen and carbon dioxide exchange in the lungs. Also, if a baby experiences persistent hypoxemia, which can result in acidosis, this leads to constriction of the pulmonary arteries. And again, the respiratory system is altered or affected by this. Please note that about 10% of neonates, when they're born, do require some degree of assistance with respiration, whether it's the use of, CPAP or just blow-by oxygen, some type of assistance. So 10%. The other 90% tend to do well and are able to just breathe on their own once they're born. Please note that as a nurse, you must be aware of the signs of fetal respiratory distress, which are cyanosis. Of course, if your baby looks grayish or has a bluish hue, we are concerned with this. Abnormal respiratory patterns such as apnea. Remember, apnea, 15 to 20 seconds is expected in a newborn. Their respiratory rate is not regular. It's irregular, so we do experience some apnea. However, more than 15 to 20 seconds would be abnormal. Tachypnea. The respiratory rate of a newborn should be anywhere from 30 to 60. So anything above 60 would be considered tachypnea. Below 30, bradypnea. Okay, retractions of the chest wall. This means your baby's having to overexert themselves to breathe. Grunting, flaring of the nostrils, and then after a while that this has been going on, the baby will experience or demonstrate hypotonia. They're really exhausted at this point. In terms of the circulatory system, there are three key structures that we need to be aware of: the ductus venosus, the foramen ovale, and the ductus arteriosus. The ductus venosus is the structure that connects the umbilical vein to the inferior vena cava. So what I like to tell students is to remember ductus venosus with a V connects the umbilical vein, that has a V, and the inferior vena cava, which also has a V, right? So V, V, V. This structure closes by day 3 of life, and it becomes a ligament, okay? Blood flow through the umbilical vein stops once the cord is clamped, obviously. And then the foramen ovale, which is the opening that we have between the atriums, that closes once left arterial pressure is higher than the right arterial pressure. And this sometimes remains opened when the neonate is experiencing hypoxia. Okay, and let's say that it closes, and then later on the neonate experiences hypoxia, it will reopen. The foramen ovale will reopen as a result of hypoxia. So this basically occurs if we have increased alveolar oxygen tension, decreased pulmonary pressure, increased pulmonary blood flow, and increased pressure in the left atrium, okay? The ductus arteriosus, same concept as the venosus. Arteriosus starts with an A. This connects the pulmonary artery, which has an A, and the descending aorta, which has an A for aorta, right? This usually closes within 15 hours post-birth. So we notice the ductus venosus closes by day 3, and then the ductus arteriosus usually closes within 15 hours post-birth. It does remain open if the lungs fail to expand. So this is what we know as patent ductus arteriosus, and this is something that we will discuss in another session. But for now, you do have to know that both the foramen ovale and the ductus arteriosus may reopen or may remain open, okay? The other and very, very important thing that we are or have to be aware of with the newborn is the thermoregulation or the thermoregulatory system of the newborn. Babies struggle to thermoregulate. They do not thermoregulate like you and I do. We shiver when we're cold to increase our body temperature. Babies do not have that capacity. What they have is what we know as BAT, okay? So, or brown adipose tissue, aka BAT. This brown fat, what's also known as brown fat, these reserves are rapidly depleted whenever the baby is experiencing cold stress. So whenever the baby gets cold, they metabolize through this brown fat rather quickly. So it is critical that the nurses are aware of the newborn's temperature and that we do everything that we can to prevent heat loss. So there's multiple ways that the babies can lose heat, right? One of them is known as evaporation. What's evaporation? When something evaporates, it's because there's water, fluid, liquid involved, right? The other one is conduction, convection, or radiation. So let's talk about evaporation. How do we prevent this? Okay, we prevent this by making sure that we dry stimulate our baby the moment that they're born. So the minute the baby's born, you grab them with a warm towel and you dry them. Okay, because the longer the baby remains wet, the more heat the baby is going to lose. That is how we prevent heat loss through evaporation. Conduction. Heat loss through conduction means you have placed the baby or you have put the baby in contact with a cold surface. So for example, let's say you forget to turn on the radiant warmer and you place the baby on a mat that is cold. That baby is going to lose heat via conduction. So the heat of the baby's body diffuses to that cold surface that the baby's coming into contact with. So how do we prevent this? Make sure that your radiant warmer is turned on and that wherever you put the baby is on top of a warm surface. If you forgot to turn on the radiant warmer, being a smart nurse, you are going to place the baby on top of mom, skin to skin, and you kind of kill two birds with one stone. You initiate the maternal and infant bonding, and at the same time, you are making sure that the baby remains warm, right? That is conduction. Then convection. I like to tell people to remember that convection is, we have convection ovens, right? Convection ovens have a little fan and they circulate air around your food so that it cooks evenly. All right, so heat loss through convection is also associated through air. If you place a baby under an AC vent, the draft of the air is actually going to take heat, body heat, away from the baby. If you put the baby next to a door that constantly opens and closes, the draft from that opening and closing of the door can also cause heat loss through convection. So how are we going to prevent it? Don't put the baby under the AC vent. Don't put the baby near a door that's going to be opening and closing because they are going to lose heat in this manner. And then radiation. So radiation is heat loss as a result of the proximity of the baby to cold surfaces. Notice how I say proximity, not necessarily contact. So it means if you place your baby next to a cold window, the heat will diffuse towards that cold window and the baby will lose heat in that manner. Or if you place the baby next to equipment or machinery that is metal and cold, the baby can also lose heat through radiation. So it is important that we do all of our interventions so that the baby does not lose heat via conduction, evaporation, convection, or radiation. We want to prevent cold stress. Cold stress is kind of the catalyst or can create a domino effect for other complications such as hypoglycemia, metabolic acidosis, the decreased production of surfactant, respiratory distress, eventually hypoxemia, delayed transition from fetal to neonatal circulation, and weight loss in a baby. Okay, some of the risk factors for these babies to develop cold stress is prematurity. The more premature the baby is, the less brown fat they have, the less they are able to thermoregulate. So it is important that we make sure that we take care of these babies, especially the premature babies, especially the babies who are small for gestational age, because they have the one thing that helps them to thermoregulate, which is brown fat. They have less brown fat than a full-term baby, for example. When we don't address cold stress immediately, you can lead to all of these problems: hypoglycemia, respiratory distress, hypoxia, metabolic acidosis, etc. So it's like a domino effect, and we want to prevent that. Okay? Signs and symptoms that a baby has developed cold stress. We have an axillary temperature of less than 97.7 degrees Fahrenheit or 36.5 degrees Celsius. The skin will be cool, they'll be lethargic, they may have pallor, tachypnea, they'll have grunting, hypoglycemia. Towards the later stages, they'll have hypotonia. They can become jittery and have a weak suck. Please note that when babies are jittery, it's not because they are cold. Remember, they do not have that capacity to shiver. They are jittery because they are hypoglycemic. Okay, so a jittery baby is, indicates that the baby is hypoglycemic, and sometimes it's not because hypoglycemia is the root cause. The root cause could just be that the baby has experienced cold stress and has gone from being cold to burning through all that brown fat, becoming hypoglycemic. Then they start having respiratory distress, etc., etc. When babies are born, the other intervention that we do besides drying and stimulating the baby is to place a stocking cap on the baby's head to reduce heat loss due to radiation and convection, right? So there's a draft that goes through the baby's head. We're not losing heat in that fashion. Please note, hypoglycemia is defined as blood glucose levels below 40 milligrams per deciliter in the neonate. So anything below that, we are concerned. Now, it depends on how low it is. If your baby has 38, a glucose of 38, what are we going to do? We're not going to sound off the alarms and go crazy. What we're going to do is feed them, okay? If the mom is breastfeeding, put them on the breast. If she's giving formula, then give them formula and stabilize their glucose in that fashion. Sometimes when the hypoglycemia is more severe, let's say they're in the 30, then you want to feed them, but you may also have to give glucose in addition to the formula. We don't only want to give glucose because it'll cause a spike and then another sudden drop as well, okay? So please note that babies who are born to diabetic moms are at an increased risk for developing hypoglycemia. Okay, so also babies that are born weighing more than 4,000 grams, or babies that are large for gestational age. So I know it's almost counterintuitive, but the bigger the baby, higher the risks are for developing hypoglycemia. Post-term neonates, again, tend to be bigger. They are also at risk for hypoglycemia. And then the other extreme, which is preterm neonates, are also at risk for hypoglycemia. Babies who have had a traumatic birth because they have been in distress. Some of the signs and symptoms are jitteriness, that's number one, hypotonia. They become irritable, they can develop apnea, lethargy, and temperature instability. Please note, NICU nurses, those of you who want to be NICU nurses, have to have excellent assessment skills because a lot of the conditions have the same signs and symptoms. So it is important that you guys review that and that you understand that. In terms of the hepatic system, let's talk about vitamin K, okay? Why is vitamin K so important? Please note, in the United States, most babies get a shot of vitamin K when they're born. And we give them vitamin K because babies do not have a intestinal flora yet, all right? Intestinal flora starts to develop after microorganisms have been introduced into the digestive tract, right? This doesn't occur until the baby has started eating. So when they're born, they don't have that. So what happens is coagulation factors 2, 7, 9, and 10, which are synthesized in the liver, are influenced by vitamin K. And since the babies do not have any vitamin K, they are unable to really synthesize all of these coagulation factors. So we give vitamin K in hopes of preventing hemorrhages in a newborn. We also have to be aware of the bilirubin. Okay, so what is bilirubin? We have two types of bilirubin. We have indirect and direct bilirubin. Okay, so conjugation of bilirubin. Please note that babies have an increased amount of RBCs, right? But they also have a shorter RBC lifespan. So they have more RBCs, but they die quicker. And then this contributes to a proportionally greater amount of bilirubin production. So when we have indirect bilirubin, this is also known as unconjugated bili, which is a fat-soluble substance, and it's produced when RBCs are broken down. And this unconjugated or indirect bilirubin is then converted to direct or conjugated bili. Conjugated bili is water soluble, all right, and it becomes, or it is converted to this form of bili by liver enzymes, all right. So direct bili, in a form, the direct bilirubin is a form that can be excreted through urine and stool. So when we have babies that have hyperbilirubinemia, we usually feed them a little bit more and make sure that they are passing meconium and that they are voiding, because they excrete a lot of the bili. When that doesn't happen and they do develop hyperbilirubinemia, that it's not, treated or doesn't resolve with just increased in formula or breast milk consumption, sometimes we have to put them, give them treatment, and we put them under a bili light. But we'll discuss that in more detail in another session. Okay, so this usually happens because we have an immature liver, right? So just keep that in mind. Please note, back to vitamin K, that vitamin K has multiple names. One of them is aquamethitone, and the other one is phytonadione. It is important that you guys know this. Common side effects of vitamin K. Vitamin K really doesn't have that many side effects, but it can cause the baby can experience erythema, pain, maybe swelling at the injection site, no big deal. And then this is usually administered IM. And depending on the vitamin K that you're using, it's either 0.5 to 1 milligram. And ideally, it is given within 1 hour of birth. So this is part of the 4th stage of labor. This is when we do our assessment, and this is when we administer vitamin K. With the GI and GU, I want you guys to know the meconium. Babies have up to 48 hours to pass their first meconium. Not all babies have a bowel movement right after they're born, right? They have up to 48 hours. So we are not concerned unless they've gone past that 48-hour mark. If it's been 49 hours and they haven't passed meconium, we have to start considering the possibility that the child does not have a patent anus, okay? In terms of urine or voiding, usually we expect babies to void within the first 24 hours. If it's been more than the first 24 hours, then we, might be concerned, and we have to start looking into possible kidney issues. Please note that moms who have been treated with magnesium throughout the labor process due to preeclampsia or whatever the reason might be, these babies may have a delay. So if you know that the baby is born to a mom who was on magnesium during labor, and maybe it's been 24 hours and the baby hasn't voided, we are a little more patient with these babies because we know that magnesium can cause urinary retention in the babies. Please note that the minimum of wet diapers after day 3, remember babies have 48 days to pass meconium, etc. So usually we want them to have on day 1, 1 stool ideally, but they can go all the way to day 2 without having one. But from day 3 onward, we want them to have at least 6 wet diapers and 3 stools. Now, in terms of stools, please note Diarrheal stools, meaning loose, and green stools are never normal. If a child is experiencing loose green stools, as a matter of fact, when we're doing discharge teaching, we have to educate the parents that if this occurs, they must call the provider, and chances are the provider is going to have them come in so that they can assess the baby. Babies dehydrate really fast, so it is important that we address these issues quickly. Babies who are breastfed, please note that their stool, after they start passing the meconium, right, when it becomes regular stool, when they're passing stool, because they've already been fed, the stool tends to be yellow. It is semi-formed, it's more pasty in consistency, and has a sour odor. Formula-fed babies, the stool is drier, it's more formed, and it's a pale yellow or brownish yellow, and it has an unpleasant odor. All right, so that's the difference. Breastfed stool, pasty, seedy, yellow, sour odor. Formula-fed babies, the stools are more formed, they're drier, but they smell really bad. Okay, so keep that in mind. In terms of the renal system, I want you guys to know that neonates usually lose 5 to 10% of their birth weight during the first week of life, and this is due to diuresis, so they start voiding a lot. And it's normal for them to lose 5 to 10% of their weight, right? How would we calculate this? Let me give you an easy example. The baby's born and they weigh 4,000 grams. And 5 days later you weigh them and now they're weighing 3,600 grams. How much weight have they lost? What percentage of weight have they lost? So if we take 4,000 and we subtract, so the original weight, we subtract 3,600 from the original weight, we have 400. So 400 is what percentage of the original weight, which is 4,000. That would be 10%. That baby has lost 10% of their original weight, which is within the normal parameters of 5 to 10%. Okay, this is expected. It happens it happens as a result of diuresis, and we're not concerned. Now, if the baby has lost 15% of their weight, then we're concerned, right, with other things. Then let's talk about the assessment. Okay. We talked a little bit about acrocyanosis, but there's this condition called circummoral cyanosis, right, which is cyanosis around the mouth. If it is transient, so it happens sporadically and then it goes away, we are not concerned. It would be considered benign. However, when this is persistent, it may be related to or indicative of cardiac anomaly. Also know that babies can experience mottling, M-O-T-T-L-I-N-G, mottling. It's basically a pattern of pink and white blotches on the skin, and this is merely a response to a cold environment. So when the baby's cold, they will experience, or you'll be able to see mottling on their skin, this white and pink blotches on the skin. Then there's the Harlequin sign, where one side of the body is pink and the other side is white. This is related to vasomotor instability, very common in premature babies and usually resolves as they mature. Vernix caseosa, it's this cheesy or greasy substance that covers the body. As the more mature the baby becomes, the less vernix that they have. When babies are born prematurely, they tend to have a lot more vernix covering their skin. So this is another indication. If we do not know the child's gestational age, because maybe the mother came in and she has no prenatal care, these are some of the things that tell us how mature or immature the baby is. How much vernix, how much lanugo they have, the creases on the soles of their feet are also an indication. Jaundice, please note jaundice, we all know what jaundice is, yellow coloring of the skin. We have jaundice that occurs within the first 24 hours. This is pathological and is usually related to problems of the liver. Jaundice that occurs after 24 hours is referred to as physiological jaundice, and it's usually related to increased amounts of unconjugated bili. Remember, unconjugated bili cannot be excreted through meconium or urine, right? It has to be converted to conjugated. So if they have, let's say they have what we know as a cephalohematoma, which is bruising as a result of the birth trauma, as those blood cells break down, they may cause jaundice, but this would be considered physiological jaundice and not pathological, okay? Molding, this is what happens when we have overriding sutures. The babies look like a little cone head, and this is normal and usually occurs as a result of the baby sitting in the birth canal, and usually resolves within a week. So caput succedaneum. Caput succedaneum is diffused edema, basically. It's localized soft tissue edema of the scalp. It feels a little spongy, and it can cross the suture line. So it's basically edema. It usually resolves again within the first week of life. And then we have what we know as cephalohematoma, which is bruising. What we know about cephalohematomas is that they're usually unilateral. They have well-defined parameters, and it takes a while. It is a bruising. It's a hematoma, but it occurs in the head, again, as a result of the birth trauma, sometimes related to prolonged labor, the use of a forceps delivery or a vacuum extractor, and it takes a while to go away. Cephalohematomas do not cross the suture lines. They have well-defined parameters, or the outline is well-defined, and again, do not cross the suture line and take a lot longer to resolve. Keep that in mind. So let's talk about the reflexes. Babies have different reflexes that we must assess when they are born. We have the Moro reflex, the startle, tonic neck, rooting, the sucking, palmar, plantar, Babinski, and the stepping or the dancing reflex. So let's talk about what these are. Please note that the Moro and the startle reflex elicit the same response. However, they are elicited differently. The Moro reflex, you usually want to jar the crib, or you want to hold the baby in a semi-sitting position and you let their head drop slightly. And this usually causes the baby to bring up both of their arms, and they make a C shape with their thumb and their index finger. In Moro reflex, you have to make a loud sound. So you would clap and the baby would startle. That's why it's called the startle reflex. The response is the same. The arms will come up, both arms will come up, and they'll make a little C with the index and the thumb. If a baby does not respond in this manner, it could be indicative of multiple things. If what you assess was the Moro reflex, meaning it was by touch, not sound, and we have an asymmetric response, which means one hand came up and the other one didn't, could be indicative of damage, temporary or permanent damage related to an injury of the clavicle or the brachial plexus. All right, if we had a shoulder dystocia where the baby was really big and the clavicle had to be fractured, when you're assessing this reflex, both arms may not come up. Well, unlikely to come up. If you elicited the startle reflex, which is by sounds, remember, and the baby does not respond with either limb, it is possible deafness, so we have to look into that, or neurological deficits. The tonic neck, we also know this as the fencing reflex, because whenever you put the baby, if you face him, if the baby faces to the right, that part of the body extends, and the opposite part, the part that the baby's facing away from, actually flexes, right? It is called, it's like fencing. The rooting reflex is elicited by touching gently the baby's cheek, and the baby will look for that finger, attempting to latch onto the finger. This is rooting, okay? The sucking reflex, we do this the minute the babies are born with a gloved finger. We put it in the mouth, and that usually elicits sucking. So the baby will start sucking your finger. We take advantage of this process, and we also assess for the soft palate and the hard palate. Make sure there's no cleft palate. The palmar reflex, I know all of us have put our fingers in a baby's hand and they grab it. It's not because they like you. It's the palmar reflex, all right? The palmar grasp reflex. The plantar grasp reflex does the same thing. If you were to put your finger right underneath the toes, the toes will curl inward. And then we have the Babinski. The Babinski is the reflex that lasts the longest, and it disappears at about 1 year of age. This is when we stroke the lateral surface of the sole in an upward motion. If they do this to you, your reaction is going to be to move your foot away and to curl your toes inward. In a newborn, it's the opposite effect. They have hyperextension and fanning of the toes. So they usually bring the foot towards you and the little toes fan outward. Then the stepping or dancing reflex is when you grab a baby. The baby could just be right out of the womb. You dry them up, you put them, or like if you're going to stand them up on a flat surface, they'll immediately start moving their feet as if they're going to walk. It is a reflex, okay? And then we have the Ballard Maturational Assessment Scale, which consists of neuromuscular maturity and physical maturity. So it is important to know that in the physical, the skin, we spoke a little bit about it. Babies, the older they get, the more peeling they have, the more cracking the skin. When we have a really premature or preterm neonate, the skin tends to be smooth, thin, and if they're very preemie, it'll be translucent. Lanugo, the younger they are, the more lanugo they have. The older they get, the less lanugo they have. Plantar creases. So obviously this is in the sole of the feet. The more creases over the greater portion of the foot, the more mature the neonate is. Ear formation. You want to make sure that you assess the form and the firmness. The more defined the ear is and the firmer it is, the more mature the neonate is. Also remember, the ears are formed at the same time as the kidneys. So when we have deformities of the ears, we usually want to assess the kidneys as well, because it could be, there could be a malformation or issues with the kidneys as well. Genitalia in the males, again using the Ballard Maturational Assessment. The greater the descent of the testes and the greater the degree of rugae or the creases, the greater the maturity. And the opposite is true, the more preemie the baby is. With the females, I already spoke about it, the genitalia. Usually you will have the labia majora covers the labia minora and the clitoris, the greater the maturity of the female. The more immature they are, the labia majora is not so developed, and usually the minora and the clitoris will be exposed. So nursing care, basically in the 4th stage of labor, this is right when the baby is born. And like I said, vitamin K is something that is done during this stage. We administer vitamin K intramuscularly, usually in the thigh, the vastus lateralis. But we also administer erythromycin ophthalmic ointment. This is an antibiotic. It's a prophylaxis treatment for gonococcal or chlamydial eye infections. In the state of Florida, this is done for every baby. Please note, for both vitamin K and erythromycin, a consent is not required. However, you must inform the parents what you're doing. You can educate them and tell them what the vitamin K is for, what the erythromycin is for, and you don't have to sign any paperwork in order for them to for you to administer this medication. However, the parent always has the right to refuse. If they refuse this treatment, this is when you have to get paperwork. They have to sign a refusal of treatment. This clears your facility of liability, right? Because if the baby becomes blind because of a chlamydial eye infection, they cannot come back after the hospital. So it is important that we know this. The same is not true for hepatitis B. Okay, this is the one immunization that we give when the baby is born. And we do require consent because it is a vaccine. So before we administer it, we have to educate the parents and make sure that they sign consent. When we administer both vitamin K and Hep B, we do one in one leg and the other in the opposite leg, just in case the baby has a reaction. The baby has a reaction, you need to know what they're having a reaction to. Highly unlikely it will be the vitamin K. However, it can happen. Anything is possible. So we want to make sure that we document in what thigh we are giving which medication. During this fourth stage of labor, the nurse should absolutely be promoting the parent-infant attachment. Remember the golden hour. This is this first hour when we want to do skin to skin, whether it's with mom or dad, significant other, whoever it is. And we also want to make sure that we allow the parents to have time alone with their child, okay, to assimilate the experience, etc. We also want to be able to identify danger signs. Remember, tachypnea, retraction of the chest wall, grunting, nasal flaring, abdominal distension, failure to pass meconium stool within 48 hours, failure to void, jitteriness, persistent hypoglycemia, persistent temperature instability, abnormal temperature, jaundice within the first 24 hours, convulsions, of course. These are all danger signs, all right? And we have to not only be aware of these, but also educate the parents on these findings and when to call their provider. Screenings of the newborn, okay? Screenings are very, very important. One of the main screenings that we do is for phenylketonuria. PKU, also known as PKU, is an inborn error of the metabolism. The neonates who have PKU are basically unable to metabolize phenylalanine, which is an amino acid found in many foods such as breast milk and formula, so foods that are high in protein. This results in a buildup of phenylpyruvic and phenylacetic acids. And what happens is, if this buildup occurs, the metabolites can actually cause permanent brain damage and even death of the newborn. And we screen for this. Please note, when the test is done, it has to be after 24 hours of formula or breast milk consumption. We cannot know if they are able to metabolize phenylalanine or not unless they have been exposed to it, right? So the same thing applies here. That logic applies here. You do this PKU test 24 hours after ingestion of breast milk or formula, and if the babies test positive for that, they have to modify their diet to have very low protein formula, or we dilute the breast milk to prevent an accumulation or a buildup of these abnormal metabolites, which can cause permanent brain damage or death in the baby. We also do a hearing screening. And you might say, why do we do that? Well, we do that because the sooner you can identify there is a disability, the better your outcomes will be. I want you guys to know the proper way of doing a heel stick. It is critical that we know this, okay? Make sure that you provide parents with the information on the test that you're going to do. Obtain the required consents. The proper way would be to warm the neonate's foot for 10 minutes by wrapping it up in a warm, moist washcloth, because this facilitates circulation to the peripheral area. You're going to don your gloves, and with your non-dominant hand, you're going to hold the neonate's foot in the dorsiflexed position. And you should have a firm grasp on the foot, but you should not be squeezing the foot. Clean the heel with alcohol and then puncture the skin in the lateral or medial aspect of the heel. So imagine that you draw a V from the bottom of the heel to the top. You want to stay outside of that V. Your puncture site has to be outside of that V. Wipe off the first few drops of blood. Allow for large blood drops to form and fall onto the testing material or the tube, the test tube that you're trying to collect the blood. Clean the puncture site and place a small dressing over it. Okay, obviously you have to document that the blood was collected, the type of test that you performed, the site of the puncture, and the response of the neonate. We can use NIPS or whatever pain measuring scale your facility uses. Immunizations, we spoke about hepatitis B. Please note, hepatitis B is usually given within 12 hours of birth if the parent, okay, has been exposed to hepatitis B or is Hep B positive. Both the vaccine and the Hep B immune globulin should be given within 12 hours of birth. The second dose of Hep B vaccine is given at 1 to 2 months of age, and then the third at 6 to 18 months of age. All right. It is important that we also know how to administer intramuscular injections. We have to always review orders, inform the parents, give them information or education on the medication that you're going to administer. Obtain the consent. With Hep B, it is important that we obtain written consent. Follow the 5 rights of medication. You have to draw up your vaccine in a 1 ml syringe, usually with a 25 gauge needle. And then you can have the parents hold the baby so that they can comfort the baby. You don your gloves, undo the diaper for full exposure of the leg, and then identify the injection site, usually again, vastus lateralis. This is where it should be. You clean the area with the alcohol swab, let it dry. It's extremely important to remove all maternal blood and amniotic fluid, particularly if we are dealing with a baby born to an HIV positive mom. Stabilize the knee with the heel of the hand. You grasp the tissue of the injection site and with your thumb and forefinger, and then insert the needle at a 90-degree angle. The medication should be injected slowly and to decrease the amount of discomfort, and then withdraw the needle and rub the site to promote absorption. Again, place a small dressing over the site and dispose of everything as you should. If it's a needle, obviously it has to go in a sharps container. Document the date, time, and location of your injection site. So let's talk circumcision. Circumcision can be very controversial. Some people think it's barbaric, others think it's necessary, others do it for religious reasons. The bottom line, or the train of thought, is that if the father is circumcised, the child should be circumcised. If the father is not circumcised, the baby should not be circumcised. The truth is that it is a matter of choice, and it depends on your culture and it depends on your beliefs. There's pros and cons, so it's up to you. Please note, babies who did not receive vitamin K, when a circumcision is done, they're at increased risk for hemorrhaging. And it would be normal for these babies to ooze. Not all of them would hemorrhage, but they can ooze a little bit more. If you assisted somebody to do a provider to do a circumcision and the baby's oozing and they did not receive vitamin K, this is something that you kind of expect, all right? You would document it, and the parents prior to circumcision need to be aware of the fact that this is a risk that they run. There are multiple tools that are utilized for this procedure. You have the Gumco clamp, the Plastibell, and the Mogen clamp. I want you guys to know this. Number 1, let's talk about contraindications for circumcision. Preterm neonates should not be circumcised, right? They can later on, but not right when they're born. Neonates with genitourinary defects like hypospadias, epispadias, right? Neonates who are at risk for bleeding problems. Maybe they have a family history of hemophilia. Or neonates with compromising disorders such as respiratory distress syndrome. Any neonate that is in distress, you should not put him in additional distress by performing a circumcision. And then risks related to the circumcision, of course, they can hemorrhage, particularly if they have not received vitamin K. There's a risk of infection, adhesions, and pain. We usually put EMLA, or we do a nerve block before we do a circumcision. That wasn't the practice before, but now we absolutely do it. And then babies, we need to make sure that they can void after this procedure. Please note, if the circumcision is performed with any of the clamps, whether it's Gumco or Mogen clamp, we want to lubricate the glands of the penis and leave the diaper loose so that it doesn't adhere to the diaper. If the circumcision is done with a Plastibell, no lubricant should be added, because the Plastibell, which should fall off within a week, will fall off before, and it would have defeated the purpose, and you basically will have an unsuccessful circumcision. So no lubricant for the Plastibell. The Plastibell will fall off on its own. And I know I've talked about this in other sessions, but babies who are not circumcised, the foreskin should not be retracted. It will detach on its own by around age 3, and parents should just be instructed to keep it clean. And that is it. So again, I hope that this motivates you to learn a little bit more about newborn assessment and learn more about what our common newborn characteristics are, and things that nurses should be looking out for in order to ensure proper newborn care. Until next time.